Hello and welcome to HPS Pharmacies webcast lecture. This lecture is focusing on bisphosphonates, their treatment efficacy and the recommended duration of therapy. So bisphosphonates are a class of medications that inhibit bone resorption. So this is particularly useful in the treatment of osteoporosis and also other conditions such as Paget's disease of bone, hypercalcemia of malignancy, and to prevent skeletal-related events in patients with malignancies involving the bone. So there's a list here of bisphosphonates that are available in Australia. So they all inhibit bone resorption. They don't seem to have a direct effect on bone formation. However, as bone resorption and formation is coupled, bone formation is indirectly reduced by bisphosphonates, although to a lesser extent than resorption. So overall, the effect is a progressive increase in bone mass. So here we have some of the typical dosing regimens for the available bisphosphonates. So as you can see, the oral agents are typically dosed regularly, either on a daily, weekly or monthly schedule. And then for the IV agents, they may be given as a single dose, for example, for Paget's disease, 3 to 4 weekly for patients with bone metastases, or in the case of zoledronic acid, it's given as an annual infusion for osteoporosis. So as a class, bisphosphonates are typically quite well tolerated. The oral agents are associated with esophageal adverse effects, such as esophagitis, esophageal erosions and ulcers. These effects can be severe, particularly in the case of alendronate. So patients really need to be reminded to carefully adhere to the recommended administration instructions to minimise this potential effect. So this would include swallowing the tablets whole and ensuring that they remain upright for at least 30 minutes after a dose. There are also some much less common adverse effects of note. So these include atypical femoral fractures and osteonecrosis of the jaw. So atypical femoral fractures is a type of stress fracture of the femur shaft, and this occurs with either minimal or no trauma. So the atypical fracture pattern can occur in patients who are not taking anti-resorptive medications. However, the risk is increased in patients who are on long-term bisphosphonate therapy, so for longer than 3 to 5 years. And the risk does increase as the duration of bisphosphonate therapy increases, and it's thought to decline after stopping therapy. In around 70% of cases, patients experience prodromal symptoms, which might include things like groin pain or pain around the upper thigh region, and this might occur in the weeks to months prior to a fracture. So patients who are on long-term bisphosphonate therapy should be advised to report any unexplained groin pain to their doctor, because if these symptoms are identified early, interventions can be initiated to prevent a complete fracture. So the rate of atypical femoral fractures is thought to be around 1 in 1,000 for women continuously treated with a bisphosphonate. And this is significantly higher than the rate for women not treated with a bisphosphonate, which is around 0.02 in 1,000. However, obviously the overall risk for all types of femoral fractures, both typical and atypical, is lower in women who take bisphosphonates. So osteonecrosis of the jaw. This was previously referred to as bisphosphonate-related osteonecrosis of the jaw. However, this term is now largely been replaced by medication-related osteonecrosis of the jaw. And this is to recognise that other medications such as denosumab have also been implicated in this adverse effect. So this is a very painful and debilitating condition, which is also quite difficult to treat. So it can be defined as bone that is exposed or can be probed through a fistula in the maxillofacial region that does not heal within 8 weeks. And before the actual osteonecrosis becomes apparent, patients may present to their doctor or their dentist with symptoms such as non-healing mucosal ulcers or loose teeth. And the exact mechanism of this effect is not completely understood. However, it's thought that maybe the bisphosphonates, due to inhibiting bone resorption, lead to the survival of old bone beyond its usual lifespan. And the capillary network to this older bone generally isn't maintained to the level that it should, which can eventually lead to avascular necrosis. And the jaw is typically more susceptible to this effect as it has a higher remodeling rate than other bones. So the incidence is higher with IV bisphosphonates, especially zoledronic acid, with most of the cases occurring in cancer patients receiving frequent IV doses. However, there are reports from oral bisphosphonates as well, and there's an estimated incidence of around 1 in 10,000 to 1 in 100,000 patients taking oral bisphosphonates. It is really important to put these risks into perspective though. So the absolute risks of both atypical femoral fractures and osteonecrosis of the jaw remains quite low for most patients. And so in most cases, the benefits of bisphosphonates in preventing fractures do outweigh the risks. So for patients who have been taking bisphosphonates continually for at least 12 months, the drugs are actually retained in the bone and do exert a residual anti-fracture effect upon discontinuation. So this is due to their high affinity for hydroxyapatite, which is the crystalline form of calcium and phosphate in the bones and teeth. So this strong binding to bone minerals allows the bisphosphonate to accumulate in the bones, where it can persist for years. And as the drug slowly dissociates from the hydroxyapatite, it continues to suppress bone turnover. So due to this enduring efficacy, the idea of drug holidays has been raised as a means of reducing the risk of complications for patients prescribed bisphosphonates for osteoporosis. And there is evidence to show that the risk of most fracture types actually doesn't increase after discontinuing long-term alendronate for many patients. So for example, in the FLEX trial, they looked at patients who were taking alendronate for a mean of 5 years. So this was in postmenopausal women with osteoporosis. And at the start of the trial, they were randomly assigned to either continue alendronate therapy or to switch to placebo for another 5 years. So compared to continued alendronate, patients who were changed to the placebo did experience declines in bone mineral density at the total hip and the spine. However, mean levels remained at or above pre-treatment levels. And after 5 years, the difference in the cumulative risk of non-vertebral fractures was not significantly different between those continuing alendronate and those who discontinued alendronate. The risk of clinically recognised vertebral fractures was significantly lower for patients who continued alendronate. However, there was no significant difference in morphometric vertebral fractures between the two groups. So the authors of the FLEX studies conclude that continuing alendronate for 10 years maintains bone mass and reduces bone remodeling compared to the discontinuation after 5 years. So among individuals who discontinued alendronate after 5 years, bone mineral density remained at or above baseline levels and bone turnover was still slightly reduced. So discontinuation at 5 years did not increase the risk of non-vertebral fractures or X-ray detected vertebral fractures over the following 5 years. However, the risk of clinically diagnosed vertebral fractures was increased in this group. So the results suggest that discontinuing alendronate after 5 years for up to 5 years does not have a significant increase in the risk of fractures for many women. However, women who are at high risk of clinical vertebral fractures may benefit from continuing the alendronate therapy beyond 5 years. So the high risk groups would be those with very low bone mineral density and those with a prior vertebral fracture. So the Horizon trial was a similar study design. So patients who were taking zoledronic acid for 3 years were then randomised to either continue zoledronic acid or be switched to placebo for a following 3 years. So in this group of postmenopausal women with osteoporosis, the femoral net bone mineral density did reduce slightly in the placebo group compared to the active treatment arm. However, it remained above pre-treatment levels. So new morphometric vertebral fractures were lower in the group receiving 6 years of zoledronic acid, but there was no difference in the rate of other fractures. So the authors concluded that many patients may safely discontinue zoledronic acid after 3 years. However, those at high fracture risk, particularly high risk of vertebral fractures, may benefit from continued zoledronic acid. So taken together, these studies suggest that 10 years of alendronate therapy reduces the risk of clinical vertebral fracture compared to 5 years, and 6 years of zoledronic acid reduces the risk of morphometric vertebral fractures compared to 3 years. And more recently, there was a meta-analysis that does support these findings further. So this study found that bisphosphonate discontinuation may be considered for women who do not have low hip bone mineral density after 3 to 5 years of bisphosphonate therapy, while women who do have a low hip bone mineral density may benefit from treatment continuation. So the current recommendations for the treatment of osteoporosis from the therapeutic guidelines suggest that patients who are not at high risk of minimal trauma fracture may consider stopping oral therapy after 5 years or IV bisphosphonate therapy after 3 years. And for patients at high risk of minimal trauma fracture, the oral agents should be continued for 10 years and IV agents for up to 6 years. And they do stress that there is a lack of evidence to guide the continuation of oral bisphosphonates beyond that 10-year mark. Therefore, in those patients at high risk, the treatment really needs to be individualised and potentially supervised by a specialist. And it's also worth noting here that most of this data on discontinuing bisphosphonates does relate to alendronate and zoledronic acid. So the evidence to guide the discontinuation of other bisphosphonates is quite limited. However, at this point, the data does suggest that the residual effects of risedronate are not maintained for as long as alendronate. So if patients do begin a bisphosphonate drug holiday, they should ensure that any other interventions to optimise their bone health are maintained. So this would include ensuring adequate vitamin D and calcium intake during that period. And it would be preferable to also consider monitoring bone mineral density, potentially after 2 to 3 years, to assess whether restarting therapy is required. So factors that would suggest restarting therapy should be considered include any significant drop in bone mineral density, a minimal trauma fracture since stopping the bisphosphonate, or new or worsening risk factors for fracture. So for example, an increased falls risk. So to summarise, there is quite strong evidence to support the benefits of a bisphosphonate drug holiday for most patients after 3 to 5 years of continuous therapy. However, any change in patient risk factors for fracture need to be considered during this period. So any increase in fracture risk is going to increase the likelihood that the patient will experience a fracture without their anti-resorptive therapy. And that would obviously diminish any potential effect, any potential benefit of a drug holiday. So the individuals most likely to derive the most benefit from continued bisphosphonate therapy will be those with vertebral fractures or very low bone mineral density. And it's also important to note that the use of drug holidays is limited only to bisphosphonates in this setting. So other anti-resorptive medications such as denosumab don't have the same long-lasting anti-fracture effects upon discontinuation. So just some self-reflection questions here. So what are the therapeutic guidelines recommendations for patients with osteoporosis who are not at high risk of minimal trauma fracture? So the correct answer there would be B and D, so stopping oral bisphosphonates after 5 years or IV after 3 years. And residual effects are likely to be maintained for longer with alendronate compared to risedronate. And the answer would be A, that is true. And which of the following patients likely has the highest risk of osteonecrosis of the jaw? So the answer there would be C, so patients receiving frequent doses of zoledronic acid. So most of the reports of osteonecrosis of the jaw have occurred in patients with cancer who are receiving frequent IV doses, zoledronic acid in particular. So that concludes today's presentation. Thank you so much for attending.